No.
Kunal वो आगे कुणाल छाड़ो तुम फॉलो करो
कुणाल थोड़ा समराइज करो
नहीं ये बोल रहे हैं व्हाई इट इज नॉट ट्यूबरकुलर ये ascites what is the difference with cirrhosis liver और इसका
Sir, in tubercular ascites there will be exudative.
उसको पकड़ो माइक को पकड़ो हाँ
बोलो तो
In tubercular ascites there will be exudative type of ascites in tuberculosis.
that is the only thing it's also
Lymphocytosis will be there. Lymphocytosis and exudative.
it's also focal hypertension will be there splenomegaly this thing will be there tubercular
Will not be there in tuberculosis. It's just a portal.
And will you be at rest?
He's coming with the conditions of sport.
We have not done this because
Endoscopy,
if we could do, it will be the esophageal varices, they will be 100%, or we can do this liver biopsy. That is another way. What I will.
Portal hypertension is not an opportunistic infection. Topic is opportunistic infection.
HIV cirrhosis liver will be tubercular
Good morning, everybody. My main motto was to stress the co-infection of tuberculosis in it. Portal hypertension is not an opportunistic infection. In our country,
Sir, a question.
I'm coming.
What is slim disease?
I will explain everything. In this particular case, the diagnosis is the HIV, AIDS on heart, co-infection with tuberculosis, causing both pulmonary tuberculosis and extrapulmonary tuberculosis in the background of clinically portal. In India, approximately 5.5 million people are suffering from HIV, and co-infection is around 35 to 40%. That is approximately 2 million people of 5.5 million people of PLH, that is the patient living with HIV/AIDS. And it is the greatest problem in the developing countries. Question is, why there is opportunistic infection, particularly tuberculosis is common. In HIV/AIDS, the CD4 count is less, and tuberculosis will occur either as a primary infection which will progressive, or it is a relapse case which indicates that the bacilli was in dormant phase. Due to the low immunity, there is relapse, or it might be due to new case, new different strain case, which can be by DNA diagnosis, which is not possible in our country. What I mean to say, if before 20 years the person was suffering from tuberculosis, At that time DNA analysis was X type, and this time if we can do the DNA analysis of the sputum culture AB, it will be different time, then it will be a different one. So there are three types of modes of tuberculosis in HIV. Due to tuberculosis infection, there will be liberation of cytokines, and these cytokines will help in the replication of HIV, and this replication of HIV increases the viral load, and viral load will cause the disease progression, and disease progression will cause the opportunistic infection. So it is found the mortality rate in case of HIV with tuberculosis is twice than the HIV alone. In normal person, suppose myself, yourself like that, the lifetime risk of getting tuberculosis is only 10% life year. That means in lifetime, we out of 100 people, only 10% may be affected by tuberculosis. But here, in case of HIV co-infection, it is 10% per year, and lifetime risk is around 60%. That is 6 times higher. The cause already I have explained. The topic was opportunistic infection in slim disease. The slim disease is HIV, and opportunistic infection occurs usually as per the CD4 count. Usually 500 to 200 CD4 count, the opportunistic infections are bacterial infection, tuberculous infection, might be herpes simplex, herpes zoster, Kaposis sarcoma, and candidal infection. When the CD4 count is 200 to 50, then there will be chance of pneumocystis jirovecii infection, cryptococcal infection, toxoplasma, cryptosporidiasis, coccidiosis. And when the CD4 count is below 50, then there is chance of histoplasmosis, Mycobacterium avium complex, that is the MAC, disseminated MAC, not original, but disseminated MAC, and CMV. CMV retinal is very common below the 50 CD4 count, and primary CNS liver. These are the common. Others may be some diarrheal infection. Our main patient is tuberculosis co-infection, so I will restrict myself my discussion with the tuberculosis. And what is the difference between the early HIV infection with tuberculosis, late HIV infection with tuberculosis? It is only for the postgraduates. Early means when the CD4 count is above 200, that is 500 to 200, and it will be just like adult tuberculosis. That means there will be cavity formation will be much more, whereas in case of late HIV infection, the cavity formation is reduced. As the cavity formation is much more, so there is more chance of sputum positivity in the early infection, that is the 500 to 200. Whereas less than 200 CD4 count, that is the late, the sputum positivity is only 20%. Number 3, in case of early infection, the infection will occur usually in the upper part, upper lobe. Whereas in case the late part, that is when the 200 below CD4 count, then it will be in the mid or auricle version. Pulmonary tuberculosis is common in case of early infection, whereas the EPTB, that is in our case, that is there is a peritoneal infection, so it is the EPTB, that is extrapulmonary tuberculosis. So that is more common in case of the CD4 count is less. And Mantoux test may be positive in case of early infection, whereas in the late infection will not get it. And complications of tuberculosis in HIV. That is very important. Why we are trying to treat the patient of tuberculosis at the earliest in HIV. The complication is much more. Particularly, patient may die of massive hemoptysis. Patient may go into the ARDS. Patient may have emphysema, or patient may have a poor pulse. So these are the 4 or 5 particular complications in case of tuberculosis with HIV. As this is a forum for this clinical discussion along with the latest development. So again, for the postgraduates, it is what are the drugs and what are the new drugs on date regarding HIV. There are 5 groups of HIV drugs. One is NRTI, that is the nucleoside reverse transcriptase inhibitor. And the first generation is gidabudin, lanibudin, diadenosine, jalcitabine. This jalcitabine is phased out because of its complications. And this emtricitabine, abacavir. And nucleotide is only one, that is tenofovir. Second group is NRTI, NNRTI, that is the non-nucleoside reverse transcriptase inhibitor. So in that particular group, previously there was belaverdin, efavirenz and nevirapine. That we are using efavirenz and nevirapine. And the 2 latest drug is in this intraverin and latest is rilpivirine. And rilpivirine has a very good drug for those who have a heart failure patients. So rilpivirine, it is the latest addition. Protease inhibitor, everybody knows, that is sacubitril, iniviravir and ritonavir. That is already phased out more or less, except ritonavir. The latest are 2 drugs. One is tipranavir and another is darunavir. Darunavir is a very low toxic drug. Along with atajanavir, this is the latest addition, and protease inhibitor I have completed. Next, entry inhibitor. Entry inhibitor means HIV cannot act on these CD4 receptors of the cells. So entry inhibitors are 2. One is enfuvatide and second is malapril. Enfuvatide, all drugs are oral except enfuvatide, which is subcutaneous every day 90 mg. And last, and which is very potent drug, that is integrase inhibitor, that is raltegravir and elvitegravir. So in new Harrison, only one drug is written, that is 19th edition, that is the rilpivirine, that is the latest drug. So regarding the treatment of heart, we can divide into 3 regimens. One is the NNRTI plus NRTI, what we are using. Second is NNRTI oblique NRTI plus protease inhibitor. And third is, when there is a heart failure, we can use the latest drugs, that is the entry inhibitor, that is fusion inhibitor or integrase inhibitor. But they are toxic drugs. So my aim was to discuss mainly the MDR tuberculosis, because in case of HIV infection, not only the patient's mortality is high, but it is seen, that is in case of patients with pulmonary tuberculosis without HIV, there is 4 or 5% of MDR tuberculosis. Whereas in case of patients with HIV infection, the MDR tuberculosis is around 14%. So this patient, our patient, may go into the MDR tuberculosis. At present, this patient was getting the stabudin, lamivudin and nevirapine. question is, we have to start the tuberculosis and tuberculosis treatment at the earliest. Otherwise, there is a chance of dissemination and patient will die. So we have to start the 4 drugs because at present category 1, 2, 3 is phased out. In RNTCP, 3 is phased out. There is no category 3. At present is category 1, category 2 and category 4. What is category 4? I will tell you. But category 3 is phased out. That means all patients should get 4 drugs. That is ethambutol, ionization, rifampicin, paracetamol. Problem is, if we give the rifampicin, then we cannot give the nevirapine. Question is why? Because rifampicin will help in the metabolism of nevirapine in the liver. So nevirapine blood level will be low. So nevirapine will not act. So that's why we have to give the rifampicin. And if we have to give the rifampicin, then lifelong patient has to continue the rifampicin. We cannot shift to the nevirapine. What I want to stress, there are only few drugs for heart. So we cannot change the drug left and right. And the drugs usually supplied from the ART centers. And patient is getting from Tata. So that's why I have not changed to second group of drugs. So because ART center should be and DOT center should be very close to his residence. It is not possible to give the dogs and the ART from garden. That's why when I have diagnosed the case, I have clearly written that it should be taken from the local center. So in that particular case, we have to start the rifampicin instead of nevirapine. And the treatment is same, that is category 1 dots. It is 2 months of intensive test followed by 4 months of continuation. And next important is this patient may go into the MDR tuberculosis or HDR tuberculosis. What is MDR tuberculosis? What is HDR? Everybody knows. Just for recapitulation, MDR tuberculosis, when the patient is symptom positive after 5 months of treatment for INH and rifampicin. And HDR is INH rifampicin. Already patient is resistant. Side by side, patient is resistant to the quinolones and 1 injectable drugs. So that is the definition of HDR tuberculosis, which is coming up at present. And what are the drugs for MDR tuberculosis? There are usually 5 groups of drugs of MDR tuberculosis. First group is only because INH and rifampicin, they are resistant, so they are not in the first group, only the pyrazinamide and rifampicin. And second group is injectable. At present, the streptomycin is not in the first line drug. It is the second line drug. Please keep in mind. So, second group, it is the streptomycin, kanamycin, amikacin, one of the injectable drugs. Third group is quinolones. Quinolones, it is mainly the moxifloxacin and lofloxacin, ofloxacin. And in written Harrison also it is written that gatifloxacin, but gatifloxacin in our country is banned. And fourth group is the bacteriostatic. Bacteriostatic mainly is ethionamide, prothionamide, para-aminosalicylic acid, cycloserine. These are the fourth group. Fifth group, which have a very doubtful role, particularly what day-to-day practice we are using, that is amoxiclav, that is clavulanic acid plus amoxicillin, clarithromycin, then linezolid, imipenem, high dose of INH. These have a very doubtful group on the fifth category. And the two latest, and another is prednisolone, that is the latest drug, and 2 important drugs for the MDR tuberculosis. One is nitroamyl group. The code name is 6387C of OPC. And another latest drug, that is the TNC 207, which is dinitroquinone. So these are the two drugs, but they have a very important effect on MDR tuberculosis, which can reduce the MDR tuberculosis treatment in a very big way. That means it is definitely hoped that it may be around 18 months. At present we are giving 24 months of this MDR tuberculosis, but in this, if you use this latest two drugs, the duration can be reduced. So these are the two latest drugs. One is the OPC 67686 and another is TNC 207. Before starting this MDR tuberculosis treatment, which is called the DOTS plus, two important things we should keep in mind. That patient should be counseled. Adherence of the treatment is very important. And second important thing is supply, regular supply of the blood. So as per RNTCP guideline, we should send the patient for this special blood center. In our welcome, and two centers are there. One is Jadavpur, another is North Bengal. Nowhere else second line of that MDR tuberculosis blood plus treatment is given. So we have to refer Jadavpur or Jadavpur. And everybody knows that in case of MDR tuberculosis, the importance of sputum positivity, sputum examination, and which is very extensive in the face. In case of ordinary RNTCP, we are doing only 2 days sputum, but here in case of MDR tuberculosis DOTS plus treatment, we have to do the sputum examination 4 days. 4 days of at the end of the 3rd month, 4th month, 5th month, 6th month, 7th month, 5 consecutive months, 4 days. At the end of the 9th month, then 3 months interval, that is 9th month, 12th month, 15, 18, 21, 22. So sputum examination, extensive sputum examination and culture is very important for the MDR tuberculosis. And in case of MDR tuberculosis, injection is given usually kanamycin, and which is daily, not in the DOTS form, that every alternate day. That is another important thing of the DOTS plus. That is, every day we have to give the kanamycin, ofloxacin, ethambutol, this pyrazinamide and cyclosen, followed by kanamycin and this pyrazinamide will be out, and it will be the ofloxacin, kanamycin, ethambutol and cyclosporin, cycloserine for another 18 months. Total 24 months, out of which patient should be in hospital stay 1 month. That is very important. Otherwise, there is a chance of drug default. Counseling is very important. And this second group of drugs is very much safe in pregnancy if it is not given during the first trimester. That is important. That is, if we can start after 12 weeks of pregnancy, it is safe. Second group of second line of drugs. There might be some teratogenicity, but not much. And in case of liver disease, we have to meet the pyrazinamide. And renal disease, we cannot use the aminoglycosid. That is the problem in case of those patients who have a chronic disease. And every month we have to take the blood for renal function test, liver function test, and third important is T4 TSH every month. Why? Answer is because patient is getting paramagnetic acid and ethionamide, which may produce hypothyroidism. So every month we have to go for diabetic RMT and therapy. So in short, I have tried to explain or I have tried to discuss regarding the